So hi everyone, I'm Christopher Tourneau. I'm a medical oncologist, a colleague from Caroline, so working at the Curie Institute, and it's my privilege to present you a clinical trial combining radiotherapy with NBTXR3, which I will name now R3. So this is my disclosure. So what we wanted to do for this first evaluation of R3 in head and neck cancer is to combine R3 with radiation alone. And for this, we decided to have a patient population that is first not eligible for cisplatin, and second, for which we think cetuximab is not the best option. So this is why we decided to include only patients who are 65 or older. This patient might have a contraindication to cisplatin, or being 70 or older, and being more than 65, as you will see, because in that patient population, cetuximab does not improve the outcome in the bonus study. So we included patients with stage 3 or 4 oropharyngeal cancer or oral cavity squamous cell carcinoma. So indeed, in the McKenzie meta-analysis, we saw that patients who are 70 or older, they might not benefit from the addition of cisplatin. Also, I agree in the clinic, so we might decide to treat some patients who are older than 70 with cisplatin if they are fit enough. But from that meta-analysis, many patients actually are not candidates for a combination with cisplatin. Now you would say, okay, but this patient might be eligible for cetuximab and there is no age limit. But in the bonus study, so what we saw in the subgroup analysis is that in patients who are 65 or older, so cetuximab might not improve patients' outcome. This is why we thought it is fair enough in that patient population to propose radiation plus a new agent, in that case, R3. So that patient population has a very poor prognosis, actually. So in all these 3 studies, the median overall survival for that patient population was around 1 year. So this was a phase 1 dose escalation study with 4 different dose levels that were 5%, 10%, 15%, and 22% of the tumor volume that was calculated based on an MRI performed within 2 weeks before starting radiation. As Karen mentioned, patient had a single injection of nanoparticles in the primary tumor only, and this was performed by surgeons under general anesthesia. So the primary endpoint was to assess dose-limiting toxicities and to establish a recommended phase 2 dose, and also to evaluate the safety and tolerability of the combination. We also wanted to see whether there were any early signs of anti-tumor activity. So again, these patients were stage 3 or 4 oral cavity or oropharynx, ineligible for cisplatin because of age or contraindication, or older than 65, where we think cetuximab might not be the best option for these patients. So in fact, we didn't see any DLTs at any dose level, so we did see some grade 1 or 2 adverse events, but radiotherapy could be delivered in a nice way in all patients, and we didn't see any unexpected toxicity related to radiotherapy. We didn't see any grade 3 adverse event, and this is why the recommended phase 2 dose actually is the highest dose level, which is 22% of the tumor volume. So this is the response on the primary tumor in the 16 evaluable patients. And you see here color codes depending on the dose levels. What you can see is that the complete responses were only seen in the 3 highest dose levels. I know it is a small sample size. Can we call this a dose effect? I don't know, but this is what we saw here. So this is here a spider plot, and we divided divided this scheme with a low dose level, so 5% of the tumor volume, and all other higher dose levels, and where we see a better results actually. So in green, you see the complete response. So you see that complete response could occur early or later. And there are still some patients who are alive without any disease progression, as you can see here with the arrow. Now there are other patients who did progress, so you can see here the white crosses, and some patients who died from their disease. But I recall that that patient population has a median overall survival of 1 year in the studies we have. So Karen showed you some pictures of patients who were injected. So indeed, we didn't see any leakage of the nanoparticles. So you see here the tumor in yellow shrinking over time and disappearing in that patient. And the nanoparticles in purple here that stay at the same place over time. So in conclusion, for that phase 1 clinical trial, so the intratumoral administration of R3 in combination with radiotherapy is safe in this poor prognosis patient population. It has a good safety profile, and anti-tumor activity is encouraging, and I will show you some data we can compare with. There is a dose expansion underway with 44 patients to be treated. So we got some data from real world actually in patients treated with for head and neck cancer between 2014 and 2017. Patients who were 65 or older, TX N+, so all patients were stage 3 or 4, and none of these patients received cisplatin. And I recall the 1 or 2 patient populations who were patients 65 and or older, T2, T3, T4, NX, but all also stage 3 or stage 4, and patients who were not eligible for cisplatin and for whom we thought cetuximab was not the best option. So it's a patient population in real world of 35,000 patients, and we could perform an analysis on 259 patients who met this criteria. So here are the results of these patient populations, patients who were not metastatic. So some of them were treated with radiation alone, some others with radiation plus cetuximab, some others underwent surgery, some started with cetuximab alone or chemotherapy, some were treated with chemoradiation, with surgery and radiation, and other treatments. You have here the median PFS depending on the treatment they received, and you can see that patients who were treated with radiation alone or radiation plus cetuximab had a PFS that was lower than the 10 months we have seen in the literature. So here is the PFS curve of these patients who were treated in real life, either with radiation alone or radiation plus cetuximab, and the median PFS is 7.3 months, and you can see that all patients have recurred before 2 years, and we know that these patients, when they recur, usually they recur before 2 years. So this is a comparison we should not do, right? But we put here the survival data we had in our cohort and this real-world data. And here is the progression-free survival, so not putting here the survival data. What you can see is that all patients had recurred within 2 years in the real world. And in our study, and this is a small sample size, I agree, we'll see what happens in the expansion cohort. We have patients who are still alive and doing well without disease progression after 2 years.